We will discuss the peripartum cardiomyopathy. This is the from topic from Williams textbooks 26th editions. What is peripartum cardiomyopathy? Usually this disorder, the peripartum cardiomyopathy this disorder is similar to other form of your non-ischemic dilated cardiomyopathy except for its unique relationship with pregnancy. The peripartum cardiomyopathy shares a genetic predispositions with both familial, it can be in familial, it can be sporadic idiopathic. It's a common genetic predisposition with both familial and sporadic idiopathic dilated cardiomyopathy. Usually it is a diagnosis of exclusion following concurrent evaluation for peripartum heart failure. After excluding other cause, you have to it will be a diagnosis of exclusions. Very, very important diagnosis of exclusions. So basically it is a diagnosis of exclusions following concurrent heart failure. Okay, this is a diagnostic of exclusions following a concurrent evaluation. When you are going for evaluations for peripartum heart failure, in case of peripartum heart failure, if you are going for a diagnosis of if you do during the evaluation peripartum heart failure, this is the case you have to do in mind during this investigating. So although the term peripartum cardiomyopathy has been used widely, until recently little evidence support a unique pregnancy induced cardiomyopathy. Report finding workshop of the National Heart Long. Okay, the development of cardiac heart failure in the definitions is the criteria, the development of cardiac failure in the last month of pregnancy. The definition of peripartum cardiomyopathy is the development of cardiac failure, very, very important, development of cardiac failure in the last month of your pregnancy or within 5 months after delivery, very, very important. So development of cardiac failure, the definition of peripartum cardiomyopathy is development of cardiac failure in the last month of pregnancy or within 5 months after delivery. Very, very important definitions for peripartum cardiomyopathy. It is a very, very important statement. It is a diagnosis, it is a disorder of very similar to the non-ischemic dilated cardiomyopathy except for unique correlations in the pregnancy. Peripartum cardiomyopathy usually they will say as a genetic predisposition with both familial and sporadic idiopathic dilated cardiomyopathy. Usually it is a diagnosis of exclusion following your concurrent evaluation of peripartum cardiac failure. The peripartum cardiomyopathy has widely used, and the definition is development of cardiac failures within last 5 months, within last month of pregnancy or within 5th month of after delivery. Okay, so you can see this is a peripartum cardiomyopathy with mild pulmonary edema. There is a pulmonary edema, you can see, and chest radiography of women with abnormally enlarged heart and with very hilar opacifications. This is the very hilar opacifications is there. Okay, this perihilar opacity with dilated cardiomyopathy. So basically the criteria to diagnose a peripartum cardiomyopathy is development of cardiac failure within the last month of pregnancy or 5 months after delivery, one, and second is the absence of an identifiable cause for the cardiac failure. There should not be no identifiable cause for the cardiac failure. Second point is absence of recognizable heart disease prior to the last month of pregnancy. So basically there will be no heart disease linking to already previously diagnosed heart disease. If there will be already diagnosed heart disease, that should not be a peripartum cardiomyopathy. So peripartum cardiomyopathy, basically there will be no absence of recognized heart disease prior to the last month of pregnancy and absence of identifiable cause for the cardiac failures, and the left ventricular systolic function dysfunctions should be demonstrated by a classical echocardiographic criteria. These include there will be a depressed ejection fractions and fractional shortening along with a dilated left ventricle. So basically ejection fraction will be less and with a dilated ventricle. These are the criteria. So basically the criteria is the development of heart failure should be within the last month of pregnancy or 5 months after delivery, and there should be absence of any identifiable cause for the disease, heart failure, absence of recognizable heart disease prior to the last month of pregnancy, and left ventricular dysfunction should be characterized by a classical echocardiography. This include depressed ejection fractions and fractional shortening along with dilated left ventricles. The incidence of peripartum cardiomyopathy very considerably depend on the population study. The average frequency is 1 is to 1000 to 400,000 bar. The etiology, very very important. What are the etiology of peripartum cardiomyopathy remains unknown. The proposed cause include: one is your viral myocarditis, one is your abnormal immunoresponse to pregnancy, because you know pregnancy there will be abnormal immunoresponse, and aberrant response to the greater hemodynamic burden of pregnancy, aberrant response to the greater hemodynamic burden during the pregnancy, and some hormonal interactions and malnutritions and inflammations and apoptosis. These are the risk factors. These are the etiology of peripartum cardiomyopathy. Usually the cause should usually unknown, and the proposed cause could be viral myocarditis, abnormal immune response to pregnancy, and aberrant response to greater hemodynamic burden during the pregnancy, and hormonal interaction, malnutrition, and inflammation and apoptosis. The current theory regarding pathophysiology is the two-hit hypothesis. The two-hit hypothesis is the current theory for the peripartum cardiomyopathy. In this regard, the peripartum cardiomyopathy, the first hit hypothesis is the peripartum cardiomyopathy is affect genetically. Usually it will affect genetically susceptible women who have one of several cardiac gene mutations. So basically the gene mutation is very very important here. The TTNC1, TTN and STAR3, very three important gene, TTNC1, TTN, STAR3. These are the already those women are susceptible to this several cardiac gene mutation. These three important mutations, TTNC1, TTN, STAR3. These are the chances that will increase. Already these are the first hit hypothesis, because this is the hit already they have in their genetically they have these genes activated mutations. Then at pregnancy at term is further characterized by prodigious secretion of prolactin. The secretion of prolactin by the maternal fertility will increase. At the same time, the placenta also secretes high level of anti-angiogenic molecules like soluble FMS like tyrosine kinase 1, that is the SFLT1. Although a number of putative triggering events have been hypothesized, that is a 16 kilodalton prolactin fragment. 16 kilodalton prolactin fragment that is called as a vasoinhibins. This vasoinhibin substance is acts to cause myocardial damage with clinically apparent ventricular dysfunctions. So basically the two hit hypothesis, the first hit hypothesis, hit 1 is your susceptibly women who has already mutation TTNC1, TTN, STAR3. Second hit is 16 kilodalton prolactin fragments, that is called vasoinhibin, that is called myocardial damage, that will cause ventricular dysfunction. This made worse by high level. This will be made worse by the high level of SFLT1, that is your anti-angiogenic factors, that is a this is the made worse by high level SFLT1, which is super abundant in women with preeclampsia. Usually the preeclampsia patients and the multiple pregnancy, and both these cases have already high level of SFLT1, that is the anti-angiogenic substance. So that will trigger the event of prolactin delta 60 kilodalton prolactin fragment, that's vasoinhibin. So basically the dopamine, the prolactin is the main culprit. So bromocriptine therapy has been evaluated because it inhibits prolactin secretion, so it has a use, supported use. But the same reasons, if you stop breastfeeding also, that will also cause a benefit effect in peripartum cardiomyopathy. The hypertensive disorder frequently coexisting with peripartum cardiomyopathy. Another proposed mechanism like links to the peripartum cardiomyopathy to preeclampsia also. Anti-angiogenic factors like known to associated preeclampsia can induce peripartum cardiomyopathy susceptible mice. So this cardiomyopathy may be precipitated by anti-angiogenic factors. In genetical physicians purpose, hosts become insufficient pro-angiogenic factors. So basically, those patients with preeclampsia, multiple gestation, already they have an anti-angiogenic factor is more compared to the pro-angiogenic factor. So there will be imbalance between anti-angiogenic versus pro-angiogenic. Again, they have a susceptible mutation, that TT1, TTNC1, TTN, and STAR3. So all this correlating. Okay. So basically, the clinical features peripartum cardiomyopathy. Compared with those hypertensive heart failures, all women with peripartum cardiomyopathy become symptomatic in the postpartum period, whereas 85% women with hypertensive heart failure develop symptoms antepartum period also. Peripartum cardiomyopathy is secondary linked with the twin gestation, smoking, echocardiographic abnormality. In contrast, hypertensive heart failure patients more often had a family history. So basically, how will differentiate the hypertensive heart failure or peripartum heart failure? So they have a twin gestation, smoking, preeclampsia. In hypertensive heart failure, they have history of family history, already say hypertension, preeclampsia in prior pregnancy, left ventricular hypertrophy. Okay, how we manage this patient? Peripartum cardiomyopathy is the same as the heart failure described earlier. The therapy should aim at volume overload, afterload reductions, rhythm controls, and inotropic support. Basically, the beta blocker therapy is to decrease mortality. Anticoagulation with LMWH is considered when the ejection fractions is raised to 30 to 35%, because that will increase the risk of left ventricular thrombus formations. So basically our management basically to be peripartum cardiomyopathy, the role of LMW when the ejection fraction is 30 to 35% because the risk of thrombosis, and you should avoid breastfeeding, and bromocriptine result in higher rate of left ventricular recovery after 6 months and lower mortality rates. And another interesting no difference left ventricular. So prognosis, approximately half of women suffering from peripartum cardiomyopathy recover baseline ventricular function within 6 months. Usually 6 months post delivery they will recover. 50% will recover within 6 months post delivery, and the rate of recovery is very slow. Usually in the obese women the rate of recovery is very slow, and the recovery depends on the baseline left end diastolic diameters. With newly diagnosed when is left ventricular dysfunction, ejection more than only postmortem. Recovery level almost 90%. Women who has baseline ejection fraction at least 30%. If minimum ejection fraction is, if it is more than 30%, the 90% will recover after 1 year. If the ejection fraction is less than 30%, then 40% will be recovered within 1 year. The mortality rate is 5 to 10% in 1 year. The mortality rate, and the preconception, in preconception of 1/3. Preconceptional period there will be 1/3 will relapse with history of PCMP. If they have a history of PCMP, 1/3 will be relapse in the preconceptional period. There will be the risk of relapse in women with persistent left ventricular dysfunction substantially higher in those of a recovered normal ventricular function before subsequent pregnancy. So management it is okay. So basically these are the